So, good evening, dear doctors and all the audience who are attending today's talk. I'm Dr. Navya K. Antony from Glenmark Medical Team. Happy to welcome all of you for this advanced training program on 2D echo techniques in collaboration with API. So, Glenmark is renowned for its commitment towards scientific excellence. So, this workshop is an innovative and a comprehensive program designed to elevate the skills and knowledge of healthcare professionals in echocardiography. So this unique initiative is developed in collaboration with the leading experts in cardiovascular medicine, aiming to provide a thorough understanding of the echo interpretation and complexities aiding in clinical practice. So this is the third webinar series, which is mainly concentrating on echo in valvular heart disease. So echocardiography is a crucial tool for diagnosing and managing valvular heart disease. It is helping in understanding and visualizing the valve structures, assessing the valve function, and evaluating the heart chamber size as well as the function and monitor disease progression and to identify the complications. So today's scientific agenda consists of, we do have 4 talks. So initially our moderator for today's event is Dr. MANISH BANSAL sir. So there is a initial contest setting from his end, followed by 4 talks, mainly talking about the mitral stenosis, regurgitation, and aortic stenosis and aortic regurgitation by our 4 renowned faculties. So we do have this session for 20 minutes. So I would ask the audience, if you have any concerns or queries related to today's topic, please post it in the chat box. So it can be addressed in the later part of the session. Also, there is a quick 3 minutes audience poll. I would appreciate if the audience can really participate by clicking the right options and help us understand your feedback of the same. So with this, I would like to welcome our moderator, Dr. Manish Bansal sir. He's a senior director and cardiologist in clinical and preventive cardiology, Medanta Hospital, the Medicity, Gurgaon. So he's a former editor-in-chief in the Journal of Indian Academy of Echocardiography and Indian Heart Journal, and as well as the former editorial board member of JACC Imaging and Cardiovascular Ultrasound. And he is also a recipient of numerous awards and honors that includes gold medals in pathology, pediatrics, and cardiology. His main interest is in academics as well as in research, and we do have more than 250 publications in PubMed as well as elsewhere. So it's proud to have you on board, sir.
Thank you.
Also, I would like to welcome our speakers and faculties for today's event, Dr. Hardeep Grewal, ma'am. She's a senior consultant cardiologist in clinical and preventive cardiology at Medanta, the Medicity Hospital, Gurgaon. She is also a teaching faculty in Mumbai for simulator courses in basic echo, advanced echo, as well as TE. And she is also certified in thoracic and esophageal echocardiography and National Board of Echocardiography. She is also having multiple accolades in her career and author of more than 30 publications in various reputed journals and textbook chapters. I welcome you, ma'am.
Thank you.
Also, pleasure to welcome our Dr. Rajesh Shah, sir, who is a director at Echo Lab in Sri Krishna Hospital, Aurangabad. He is also assistant professor in the medicine in MGM Medical College, and he have organized a conference, especially in echocardiography, and executive committee member of multiple organizations and faculty National Echo Conference. And he has also published his second edition of Echo Learning DVD labels, especially on the topic of illustrative video manual of echocardiography, a step-by-step approach. Happy to have you on board, sir. Also, I would like to welcome Dr. Harin Vyas, sir, who is a consultant cardiologist and head at Non-Invasive Cardiology Fortis Hospital, Mulund, Mumbai. He is also a member of Royal College of Physicians, UK, and he is also pioneered in advanced echocardiography services at Fortis Hospitals. And he is a BSc accredited echocardiographer and expert in strain imaging, contrast, and 3D echo. And he also have multiple publications, like 15 more research papers and articles in peer-reviewed journals and multiple chapters in the textbooks, especially published in India and also worldwide, that is UK. Honor to have you on board, sir. It's my pleasure to welcome our last speaker, Dr. J.C. Mohan, sir. He's a chairman and Institute of Heart and Vascular Disorders, Jaipur Golden Hospital, New Delhi. And he's also a former consultant in Apollo Multispeciality Hospital, Kolkata. And, he's also a fellow membership in multiple conferences And he has various accolades in his career, such as Sujoy Roy Gold Medal Award for the Young Investigator in 1988, as well as Searle Award for the Best Investigator in the same year, and Health Minister Awards for Distinguished Service in 2002. And he's authored multiple papers, more than 250 research articles, and more than 50 book chapters. Great to have you on board, sir. So with this welcome, I now hand over the session to our moderator, Dr. Manish Bansal, sir, for taking over the session ahead. Over to you, sir.
Yeah. Okay. So good evening, everyone. And thank you, Dr. Anthony, for this nice introduction and setting the stage. And I also thank Glenmark for creating this platform for discussing various disease conditions as they apply to as they are relevant for echocardiography. Now, today we are going to talk about valvular heart diseases, which are amongst the commonest cardiac conditions that we encounter in day-to-day clinical practice. As has already been mentioned, echo is undoubtedly the most important diagnostic modality used in the evaluation and management of valve lesions. It is important right from the initial assessment of the diagnosis, nature, severity, and mechanism of valve lesions to guiding the treatment of the valve lesions inside the operating room or the cath lab, and then subsequent follow-up. So without wasting any further time, I'll request first speaker, Dr. Hardeep Grewal, who's my colleague at Medanta, to speak about mitral stenosis.
Good evening, everyone. Am I audible? I just want to
Yes,
confirm.
ma'am.
Okay, thank you. So today I'm going to talk about echo in mitral stenosis. So just one second. Yeah. I've lost my actually presentation. Can you see my presentation?
Yes, ma'am. We can see the role of
I'm
echo.
actually I'm not able to see my presentation.
Ma'am, can you unshare and share once and see?
Yes, I'll do that. So I'm sorry, I will share it again.
Yeah, no issues, ma'am.
Yes. So as we all know that echo plays an extremely important role in the evaluation of mitral stenosis. Not just that it confirms the diagnosis, it also helps in the assessment of the etiology. What is the severity of mitral stenosis? What is its hemodynamic impact? And very importantly, it helps in planning the intervention, whether this patient is a good candidate for BMV or is a good candidate for mitral valve surgery. So in today's presentation, we will walk through all of these parameters and how do we assess these parameters on echo. So starting with the etiology of the mitral stenosis. So rheumatic heart disease, degenerative mitral annular calcification, these are the main etiologies, and there are less common causes like congenital causes, inflammatory, infiltrative, or drug-induced valvulopathies, and very rarely carcinoid can also involve left side of the heart. Now, out of all these etiologies, rheumatic heart disease remains the most common etiology worldwide, especially in the endemic regions. And as we can be illustrated in this bar diagram, that RHD accounts for most of the cases in all age groups, except in patients who are more than 80 years old, where the degenerative mitral stenosis is more common. Now, degenerative mitral stenosis, the prevalence is increasing and it is common in patients with multiple atherosclerotic risk factors. Now, since rheumatic heart disease is the most common etiology, so let's look at a classic rheumatic mitral stenosis echo images. So this is the parasternal long axis view, and as we can see that the mitral valve leaflets are thick, and the thickening is predominantly at the tip of the mitral valve leaflets, and there is significant restriction at the tip of mitral valve leaflets, and the basal and mid portion of AML, as we can appreciate here, is spared, is pliable. So this is very characteristic feature of rheumatic heart disease, and this gives rise to a typical doming of the AML during diastole, giving rise to a hockey stick appearance. The other important feature of the rheumatic heart disease is when we look at the mitral valve in the short axis. So this is the parasternal short axis at the level of mitral valve leaflet tips, and we can appreciate that the mitral valve orifice is significantly reduced during diastole, and this reduction is basically because of the thickening of the mitral valve leaflets, and this is giving rise a very classical fish mouth appearance to the mitral valve orifice. Now, this is primarily because of the commissural fusion. So both of the commissures in this patient are significantly fused, and this commissural fusion is actually the hallmark of rheumatic heart disease. Now, another feature which is quite classical of rheumatic heart disease is the involvement of the subvalvular apparatus. Now, here we can see that the subvalvular apparatus, that is the chordae up till the back muscle, they are significantly thickened and fused and shortened. Now, this is also a very classical feature of rheumatic heart disease, and this thickening can be graded from grade 1 to grade 4 depending upon the extent of the subvalvular involvement. Now, when we are looking at a patient who's got rheumatic mitral stenosis, we would also see that sometimes other valves are also involved, as in this patient where patient has got significant mitral stenosis as well as aortic stenosis. And we also need to look at the tricuspid valve and pulmonary valve, because rarely those valves can also have rheumatic involvement. Now, all these features, they show a typical rheumatic pattern. Now, there is another etiology of the mitral stenosis which can be confused with the rheumatic heart disease, and it is not uncommon to label this entity as rheumatic heart disease falsely, and that is degenerative mitral stenosis. Now, it is very important to make this distinction between these two entities, because the treatment strategies are totally different. Rheumatic heart disease, where the patient can undergo BMV, where in degenerative mitral stenosis, BMV is not an option. In fact, the surgical intervention is also technically very challenging in these patients. Now, how do we differentiate it? Now, so I've put both the images side by side for easier comparison. So if we look at this image, so unlike rheumatic heart disease, where the leaflet tips are significantly involved and are restricted, in the degenerative mitral stenosis, the striking feature is the mitral annular calcification, as we can appreciate in this parasternal long axis view. And we can see there is dense calcification of the posterior mitral annulus, and the leaflet thickening, as we can see here in the AML, is basically involving the basal portion and mid portion. And in this four-chamber view, we can see that there is significant thickening of the mitral valve leaflets, but the tips are spared. So unlike rheumatic heart disease, where the tips are involved in degenerative mitral stenosis, even if the disease is quite extensive, the tips are spared. So that is a very important feature to differentiate between these two entities. The other thing is that if we look at the short axis of the mitral valve, you may still appreciate that the mitral valve excursion is a bit limited, but there will not be any commissural fusion, and there won't be any subvalvular involvement as in patients with rheumatic heart disease. So careful morphological assessment of the mitral valve can help us in differentiating between these two entities, and which is very important. Now let's look at another case. So this was a very young girl, actually 16-year-old, who presented to our hospital with the diagnosis of rheumatic heart disease with severe mitral regurgitation and aortic regurgitation. So do you think that this patient has got rheumatic heart disease? Now, if we look at the mitral valve leaflets, they are thickened, but the thickening is mainly at the bases, and there is no commissural fusion as we can see in the short axis of the mitral valve, and there is no commissural fusion in the short axis of the aortic valve. So, and there is hardly any subvalvular involvement. So this patient actually turned out to be a case of Takayasu's arthritis. So it is not uncommon to think of rheumatic etiology in a patient who is young and presenting with thickened mitral valve leaflets. But if the echo features are not typical of rheumatic pattern, and especially when there is another systemic disease which could be responsible for this mitral valve thickening, so we should think of alternative diagnosis as well, as in this case the thickening was because of the valvulitis secondary to systemic inflammatory disease. Now, once we have assessed the valve morphologically and have decided about the etiology, next step is to look at that what is the severity of the mitral stenosis. Now, as far as degenerative mitral stenosis is concerned, we do not have any guideline-based proper criteria to differentiate between different categories of mitral stenosis. But so therefore, I will limit my discussion mainly to the rheumatic mitral stenosis, which is more common, and we have the latest these criteria which are given by ASC in 2023 in the guidelines on rheumatic heart disease. Now, in this, the multiple parameters they have been proposed for the assessment of mitral stenosis. They were there in the previous guidelines also. The difference is that now the cutoff for mitral valve area has been changed from 1 to 1.5 for severe mitral stenosis, and for PHT the cutoff is 150 milliseconds. So we will go through all of these parameters one by one. How do we take them, and what are the limitations of each parameter? So let's start with the simpler parameter, which is easy to use and very commonly used, that is transmitral pressure gradient. So pressure gradient is it is actually the gradient between the left atrium and the left ventricle during diastole, and as the mitral stenosis severity increases, this gradient also increases. So now let's look at how do we take it. So usually we use continuous wave Doppler, and the idea is to align the Doppler signal parallel to the flow of blood in the mitral inflow. So we use apical four-chamber view, but sometimes in rheumatic heart disease, there is significant involvement of the subvalvular apparatus. As a result, the mitral inflow could be very eccentric. So we may have to use apical long axis view, or sometimes we use tilted views to align our signal, and so that we get the best gradients. Now, once we have done that, then we will get this spectral display. As we can see here, this is above the baseline because the blood is flowing from the left atrium to the left ventricle. And once we have got this, then the next step is to trace this signal. Now, when we are tracing it, so the way this signal has been traced, this is wrong method. Why this is wrong? Because once we have obtained the signal, we need to optimize the signal. So how do we optimize this? We optimize the gain setting, as we have done here. We optimize the scale, and we optimize the horizontal sweep. And then we trace the signal. Now I'm showing you two, same signal has been traced twice. Now this is the wrong method to trace, and this is the right method. Now, why this is wrong? Because here we can see that we have traced the feathery signals also, the fringes also. So this is not the correct method. So we should trace only the dense outer border, and we should ignore the feathery signals. Now, in this particular patient, when we were tracing the feathery signals, the mean gradient was 20 millimeter of mercury, and here it is 16. Now, it may not be very relevant in this particular patient because the patient has got severe mitral stenosis and the gradients are in the severe range. But this becomes very relevant when we are dealing with borderline severity stenotic lesions. Now, in patients who has got atrial fibrillation, it is recommended because there is a beat-to-beat variability. So we should take average of at least 5 cardiac cycles, and then the average from all these will give you the mean gradient. And nowadays, the machine automatically trace the 5 to 10 cardiac cycle and gives you the average. Now, mean gradient, it's a very simple parameter, and as per guidelines, if the gradient is more than 10, that indicates severe mitral stenosis. But we have to be very mindful of the limitations of the gradients, that gradients are highly flow dependent. So it may you may have a situation where the patient has got severe mitral stenosis, but the gradient is less than 10, or patient has got non-severe mitral stenosis, but the gradient is more than 10. So if a patient has got tachycardia, the gradient is going to be high. If the patient has got bradycardia, the gradient is going to be low. So we need to be mindful of all the limitations and on what factors the gradients might depend. And this also emphasizes the fact that one single parameter is not sufficient to grade the severity of mitral stenosis. We need to look at other parameters. Now let's look at the other parameter. The other parameter, which is again a Doppler-based parameter, is pressure half time. Now, this gives an estimate of mitral valve area by using the formula 220 by PHD. Now, what is pressure half time? So pressure half time is actually the time required for the pressure gradient across the valve to fall from peak value to half of its value. right? So how do we trace it? So we basically what we do, we just trace the take the deceleration slope of the mitral inflow, and the machine will automatically calculate the PhD, and from PhD it will give you the mitral valve area. So generally it is very straightforward. There is a straightforward method to measure it, but sometimes there may be a challenge when you get this kind of slope. So here we can see that this slope is a bimodal slope. There is initial steeper portion and then there is a flatter portion. So this kind of slope can be seen when in patient of rheumatic mitral stenosis, when left atrium is non-compliant. So here the challenge is that where should we take the deceleration slope? Should we take the initial steeper portion? Should we take the later flatter portion? Now, first we need to understand why the steeper portion is there. Now, because the LA is non-compliant, so as soon as the mitral valve opens, there is a rapid rush of blood from the left atrium to left ventricle. So that is why there is this initial steeper portion followed by mid-diastolic flatter portion that actually truly reflects the mitral stenosis severity. So if we are tracing the initial steeper part of the slope, then we are going to overestimate the mitral valve area by pressure half time. So we have to take this mid-diastolic slope. Now, in the mid-diastolic slope also, we have to make sure that where we are putting our initial points. So we have to start from the beginning of this slope. We need to extrapolate this slope backwards. And beginning of somewhere like here, assuming that if the LA compliance has been normal, then this would have been the initial pressure point. So that would give you a reasonably reliable mitral valve area by PhD. Now, in comparison to mean gradients across the mitral valve, the PhD has the advantage that it is not significantly affected by the flow across the valve, but it has its own limitations because it depends upon the pressure decline between the two chambers. So if there is LA compliance or LV compliance is altered, then the PhD may not be reliable. As we have just seen that if LA is non-compliant, you will get a steeper slope, which may overestimate the valve area. And similarly, if LV and diastolic pressure is high for some reason, as in AR or in diastolic dysfunction and severe aortic stenosis, then PhD may not be reliable. So again, we need to be mindful of these limitations when we are interpreting the mitral valve area by PhD. Now, as we know that mitral valve area by PhD is an indirect measure of the mitral valve area. It's an indirect estimate. So more direct method is mitral valve area by planimetry. So this is actually the gold standard method to assess the mitral stenosis severity. So what you do, you basically make a parasternal long axis view, a proper parasternal long axis view, and then you turn the probe clockwise and you get a short axis at the mitral valve leaflet tip. Now, it may appear quite simple, but the thing is that we have to ensure that we are cutting this plane is at the tip of the mitral valve leaflets, because the maximum restriction is at the tip of the mitral valve leaflets. So how do we ensure? Because if we are not ensure, if we are cutting not at the tip but beyond that, then we are going to overestimate the mitral valve area. So in 2D echo, what we can do the sweeping technique. So once you have make a short axis at the level of mitral valve leaflet, then you just go back to the pap muscle level and then start tilting back the transducer towards the base of the towards the base of the left ventricle. And as soon as you recognize the narrowest mitral valve orifice, that is the point where you will measure will acquire that frame. Now, other method beyond 2D is that if you have a 3D transducer, then we can make use of biplane imaging, where we can acquire two cross-sectional views at once. So you can make a parasternal long axis view, then you can align the cursor at the tip of the mitral valve leaflet, and the software, the 3D transducer, it will automatically give you the cross-sectional image at the level of your cursor. So this is another method by which you can ensure that you are capturing the narrowest portion of the mitral valve orifice. The other method is sometimes what happens that the mitral valve orifice is very oblique and it is just not possible to make a good parasternal long axis view. And then we can make use of 3D multiplanar reconstruction, where we can do cropping and multiplane to visualize the narrowest mitral valve orifice. Now, once we have acquired the mitral valve image at the tip of the mitral valve leaflets, then there are a few other things which we need to take into account. That the frame which we choose to measure to trace the mitral valve area is the mid diastole. We avoid tracing in the early diastole or in the late diastole. The other thing is that we have to optimize the gain settings, because if the gain settings are too high, we are going to underestimate the valve area. If the gain settings are too low, we are going to overestimate the valve area. So the gain settings should be optimized. The other thing which we need to take care of to take into account, if the patient had already undergone BMV, in those patients sometimes the commissures are open. In those patients, if the commissures are open, then ideally we should include the commissures also while planimetry. So these are the few things which we need to take into account for accurate assessment of the mitral valve area using mitral valve area planimetry. Now, the ASC guidelines has suggested to use multi-parametric approach. We should not rely on just one single parameter. As we have just discussed, that different parameters, they have their own limitations. Now, generally, if all of the parameters are falling into one category, either in mild, moderate, severe, all of these parameters are concordant, then usually there is not much of a confusion regarding the severity of the mitral stenosis. The confusion happens when the numbers are not matching. When the planimetry says that the mitral stenosis is severe, but the gradient is low or the PhD is not concordant with the planimetry. So I have just summarized some of those conditions which can happen and which can cause discrepancy of different parameters. Now the rule is that if we look at that, if two of the three parameters, that is planimetry, for example, planimetry is suggesting significant mitral stenosis, gradient is suggesting significant mitral stenosis, but the PhD, for example, in this case is suggesting non-significant mitral stenosis. So if two parameters are pointing towards one category, that means that we are dealing with that grade of severity. So now, when can this happen? We need to be think of that also, that why this particular parameter is not concordant with rest of the parameters. For example, if a patient has got significant mitral stenosis by planimetry, the gradients are high, but PhD is suggestive of non-significant mitral stenosis. We have just discussed that this can happen if the patient is non-compliant LA or if the LVEDP is very high. Similarly, if a patient has got significant mitral stenosis by planimetry, but the gradients are low, then this can happen. We know that this can happen in bradycardia. This can happen in low cardiac output state in patients with CHF or in patients with severe TR or TS. And likewise, so there are, so we need to, again, emphasizing the fact that we need to look at all of the parameters, and also in context of the mitral valve morphology. If the planimetry says that the mitral valve is not that significant, but the gradients are high, and visually also you can see that the mitral stenosis doesn't look that severe. So you need to take into a context take into account the morphological appearance of the mitral valve as well. So I will just show you an example here, just again emphasizing that how.
Yeah, we'll have
Just
to finish in 2 minutes. Yeah.
Yes, sir. So this is a patient a young lady who had rheumatic mitral stenosis, mitral valve area 1.2 centimeters square. And if we look at the gradient here, mean gradient is 23 and mitral valve area by PhD is 0.8. So two parameters are pointing towards significant mitral stenosis here. Now in this patient, if we look at the valve, it doesn't look that significant in comparison to the PhD and gradients. So this patient had actually high gradients because this patient had significant subvalvular stenosis resulting in a funnel-shaped mitral inflow, and which is explaining the PhD as well as the increased gradient. So that is why it is important to look at the morphology and the subvalvular apparatus. Now, when we are deciding about the treatment in a patient of mitral stenosis, we have a few parameters. The Wilkins score is quite popular because it helps in predicting how well a patient will respond to BMV. I will not go into detail of each of these parameters, but if the valve is significantly thickened and calcific, if the commissures have calcification, if the subvalvular thickening is grade 3 or grade 4, then this patient may not be a very good candidate for BMV. And again, emphasizing that when we are writing reports for rheumatic heart disease, mitral stenosis, we need to write about all these features. And another scoring system based on commissures. If the commissures are fused and non-calcific, that means greater is the likelihood of successful commissurotomy in these patients. So many times we have to do TE also to rule out left atrial appendage clot and to look at the severity of mitral regurgitation, which could be another factors impacting the outcome of the BMV in a patient. So in the end, I would like to conclude by saying that we need to carefully identify the morphology of the mitral valve to distinguish between RHD and degenerative mitral stenosis. And again, we need to look at all of the parameters in context with the morphological appearance of the mitral valve, because every parameter has its limitation and we need to be mindful of that. Thank you.
So this was a very nice description of echo assessment of mitral stenosis. And now we will quickly move on to the next presentation. We will take all the question answers at the end of all the 4 presentations. So I now invite Dr. Rajesh Shah, who's a very senior physician and expert in echo from Aurangabad. He will be speaking on mitral regurgitation.
My screen is visible?
Yes, sir.
Okay. I thank the organizers for giving me this opportunity. I'll be talking on mitral regurgitation, a condition which is very easy to diagnose, but at the same time can be very difficult to evaluate. The slide is not moving. Regarding the anatomy, I will not go in much detail, but I would just like to say that it is just not the leaflets that are important, but it's the whole apparatus, right from the left atrial wall, annulus, leaflets, chordae, papillary muscles, and even the left ventricular muscle where the papillary muscles are attached. A brief overview about the scallops. The posterior mitral leaflet is divided into 3 different parts by two fissures known as the P1, P2, and P3 from the lateral to the medial side. Correspondingly, anterior mitral leaflet is divided into A1, A2, and A3 from the lateral to the medial side. To identify these scallops, mostly in the parasternal long axis view, in the neutral position, we will be seeing the A2 and P2. Tilting the probes can even give us some idea about the A1 and A1 P1 and A3 P3, but that will not be very accurate. In the apical 4-chamber view, in the neutral position, it will be mostly the P1 and A3, and many times because the tongue-like shape of the AML, the A2 may be seen in the center. Similarly, in the 2-chamber view, we will be seeing the P1 and P3 with many times A2 scallop in between. Coming to the evaluation, the 2017 guidelines by the ASC and the AHA is quite useful. They have given a lot of importance to the etiology and mechanism of MR. The etiology, it may be either primary MR or it may either be secondary MR. In primary MR, the valve is responsible for making the heart sick, while in secondary, the heart makes the valve sick. These are the different conditions in the primary MR, mostly rheumatic, infective, ischemic, degenerative, and congenital. We'll be seeing each one of them. While in secondary, it may be because of atrial cause, where the atrium has become dilated, either from diastolic dysfunction or atrial fibrillation, and it causes atrial functional MR. While in maybe also because of ventricular dilatation, where from any cause, again giving rise to non-cooptation of the leaflets. So 2D echo, it will give us an idea about the anatomy, that is whether it is functional or organic, acute or chronic, and give us an idea about the LV and LA dimensions. The Doppler is quite useful for the quantitative evaluation of MR, while 3D, it is more authentic, and the en-face view helps the surgeon during intraoperative procedures. So echo will tell us when, what, whether repair or replace or a catheter paste procedure is okay. Coming to the degenerative mitral valve, these form the major chunk of the MR cases, and it is nothing but a spectrum right from fibroelastic deficiency to Barlow's disease. In fibroelastic deficiency, we will see that it mostly occurs in the elderly, where the leaflets are quite thin and they are prone for caudal rupture. Myxomatous valve is thick and usually shows bileaflet prolapse, while Barlow's disease is the extreme form where the leaflets are very thick and mostly because of the mucopolysaccharide deposition, and it is usually seen in the younger age group. Another way of classification is the surgical classification given by Carpentier, a French cardiothoracic surgeon, into type 1, type 2, and type 3. In type 1, the mobility of the leaflets is normal. In type 2, there is excess mobility beyond the annular plane. In type 3, there is restriction of the mobility. It is divided into two, that is type 3A, where there is restriction in and diastole, while in 3B, there is restriction only in systole. Let us see examples of each of them. One example, that is the atrial functional MR, where the atrium is responsible for dilatation of the annulus. As I told you, maybe in diastolic dysfunction or atrial fibrillation, and the annulus usually dilates more than 37 millimeters, preventing the coaptation of the leaflets. Here one should keep in mind that the leaflets are still on the ventricular side. Now, coming to the another example, that is the perforation of the leaflet, may be iatrogenic or may be because of endocarditis. And here, again, the mobility is normal. Coming to type 2, where there is excess mobility, the classical example is the prolapse of the leaflet, where the leaflet goes beyond the annular plane into the LA more than 2 millimeters. Flail leaflet is an extreme type of type 2, where the leaflet points into the left atrium and gives rise to an eccentric jet. The direction of the jet here can help us to know which leaflet is prolapsing. Usually, when there is prolapse, there is a opposite direction of the jet. If posterior leaflet is prolapsing, it will give a jet which is directed anterior and medially and vice versa. The third type, that is restriction in systole and diastole, the A variety, the classical example is rheumatic heart disease, where there is MS and MR together. Type 3B, where there is restriction only in systole, is usually due to ischemic remodeling. Here we can see, because of the inferior wall infarction, we can see that there is scarring of the basal inferior portion, and the PML cannot coapt with the AML, giving rise to posteriorly directed jet. The second type of 3B, that is the ventricular type, where dilatation of the ventricles from any cause gives rise the apical and lateral displacement of the papillary muscles. Thus, the coaptation cannot occur, giving rise to a central jet. And SAM is another example seen in HOCM, where there is systolic restriction giving rise to a LVOT gradient and a posteriorly directed jet. Now, the another way in which the mitral regurgitation can be classified is the acute or chronic. If we have a clinical condition like acute myocardial infarction, endocarditis, mitral valve prolapse, where acute condition can occur, and if such patient suddenly develops hypotension and pulmonary edema and has a soft murmur with hyperdynamic LV, one should have a high suspicion of acute MR. An example of acute MR, you can observe that the LA and LV are quite normal in size. The AML is prolapsing, and there is a severe eccentric MR jet. When it is flail, usually in 85% of the cases, it is severe MR with a regurgitant volume more than 100 ml. Coming to chronic MR, before even we start evaluating, we should be very clear whether it is a hollow systolic MR or it is just an early or late systolic MR, because this is going to change the way we quantify MR. The 2D echo, as I have told you, will give us the idea about the tethering, whether it is prolapsing or flail, with how the coaptation of the leaflet is, calcification, vegetations, if they are present or not. And also it will give us an idea about the chronicity by the LA and LV volume. It will also help us for serial follow-up. Coming to the color flow evaluation, the jet has three main parts. That is the flow acceleration zone, then the narrow vena contracta, and the jet itself. Each part can give us a semi-quantitative or quantitative idea about the severity of the MR. Before we start color flow evaluation, certain things that we should keep in mind, such as the jet momentum, entrainment, color gain settings, PRF settings, direction of the jet, and area of flow acceleration. Here, the momentum, that is usually the systolic blood pressure. If it is very high, the gradients are going to be more, and we are going to have a severe MR. But the same patient, if we control the blood pressure, the grade of the MR will reduce. So always we should report at what blood pressure we have examined the MR. Second is entrainment. One must have observed that in the bowling alley, the first bottle is only hit and the impact goes to the other bottle. Similarly, when the jet passes into the LA, it will set into motion the surrounding RBCs. So therefore, the centrally directed jet will always appear larger than what they actually are. Similarly, color gain setting, if it is too low, the MR will appear smaller or lesser in grade. And if it is high, it will even catch the very low velocity RBCs surrounding the jet, and it will appear larger. Similarly, if the Nyquist limit, if it is set very high, we will not catch the aliasing of the low velocity RBCs, and opposite will occur if the Nyquist limit is very low. Roughly, we always keep the Nyquist limit around 50 to 70 centimeters per second. The Konda effect, which is the tendency of the liquid, you must have observed. If you try to empty a vessel, the fluid sticks to the wall because of the surface tension. Similarly, if we have eccentric jet, the jet will stick to the wall and it will appear smaller than what actually it is. Whenever we have one way of quantifying the MR semi-quantitatively by color flow is the extent into the left atrium. If it is just beyond inside the leaflets, it is grade 1. Up to the annular ring, it is grade 2. 2 centimeters beyond the annulus, it is grade 3. And if it reaches the LA wall or there is a flow reversal in the pulmonary veins, it will be grade 4. Such evaluation is usually very misleading in cases of eccentric jets. ASE has given certain signs. These are the specific signs, supportive signs, and the quantitative parameters. Let us see one by one. Number one is the jet area, very simple. After we have adjusted all the things which I have just now told, we just take planimetry of the MR jet. Less than 4, 4 to 8, and more than 8 square centimeter constitutes mild, moderate, and severe MR. We should take multiple views, otherwise we may be misled. Another entity that has been advocated many times is the ratio of the MR jet to the LA jet, LA area. This is because that many times in LA we will have very large LA. Less than 20, 20 to 40, and more than 40% of the LA area constitutes mild, moderate, and severe MR. Coming to the second very important robust sign is the vena contracta. It is the narrowest part of the jet, and it is usually distal to the actual anatomical opening. And we can say that it is a physiological opening, because all the signs, symptoms, and grades are on the basis of the vena contracta. It is usually measured in the parasternal long axis or the four-chamber view, because we have a better axial resolution. And it is never measured in the two-chamber view. Less than 3, 3.1 to 6.9, and more than 7 vena contracta width constitutes mild, moderate, and severe MR. It is acceptable in aortic regurgitation, eccentric jets, and under any loading conditions. Nowadays, in the days of the 3D echocardiography, direct measurement of the vena contracta area is quite helpful. It will also give us an idea whether it is organic, where the area is usually circular, opening is usually circular, while in secondary MR, it is crescentic. Now, semi-quantitatively, the flow acceleration zone can give us an idea about the severity, disregarding whether it is central or eccentric jet. If we have a nice flow acceleration zone without shifting of the baseline, then it usually indicates severe MR. All the specific signs have high positive predictive value. Coming to the supportive signs, the pulmonary vein evaluation, if we have a high velocity of the E wave compared to the A, it is more than 1.2 meters per second, it usually indicates severe MR. While if there is A predominant, it excludes MR. Like the dimensionless index in aortic stenosis, if the mitral to aortic VTI is more than 1.5, it indicates severe MR. Another very important evaluation is the pulmonary vein evaluation. We can see here that normally the systolic wave is much or little more than the diastolic wave, but as the severity of MR goes on increasing, the systolic wave becomes blunted. And in severe MR, it will become, there will be reversal of the flow in the systole. It will not be very reliable in dilated and compliant left atrium, in eccentric MR jets, atrial fibrillation, and in the elderly. It again has a positive predictive value. The continuous wave Doppler through the MR jet, the shape and the density of the spectrum gives us a fairly good idea about the severity of MR. If it is parabolic, symmetrical, and light in shade, it is usually mild MR, while if it is dark and there is a sudden cutoff, it indicates severe MR.
Dr. Shah, we'll have to
Yes.
finish in 2 minutes.
Yes, sir. Then the size of the LA, more than 34 ml per meter square, end systolic dimension more than 55, or left end end diastolic dimension more than 70, all constitute severe MR. End systolic dimension is quite useful because it reflects the LV shortening, the volume overload. It tells us about depressed LV and mitral wall regurgitation. Pulmonary hypertension, if it is present without any other cause, also indicates severe MR. Coming to the mitral, this volumetric method, based on the Newton's law of conservation of mass, the flow across all the walls is usually equal, provided there is no shunt or AR. Here the formula is that the flow per beat is equal to area into VTI. Here we calculate the flow across the mitral wall and flow across the LVOT. Care being taken that the sample volume is at the annulus and not at the tips. So if we subtract the LVOT flow from the mitral wall flow, we will get the MR volume. Once we get the regurgitant volume, regurgitant fraction will be regurgitant volume divided by the mitral wall flow into 100. We know that the regurgitant volume is area into VTI. So area of the EROA will be regurgitant volume divided by the VTI. Advantages that it is quite accurate but time consuming. It can be used in multiple jets, in eccentric jets, and in mid and late systolic MR also. Disadvantage that expertise is required. It is cumbersome, and mitral NNO flow may not be very accurate. Coming to PISA, it is a hydrodynamic principle where when the fluid passes through a narrow orifice, it forms hemispherical shells of increasing velocity and decreasing surface area. The method is that we shift the baseline in the direction of the MR jet so as to increase the size of the flow acceleration. We measure the radius, and by this, we get the regurgitant flow, that is the 2 pi r square into the velocity which we have set around 20 to 40 centimeters per second. And ERO will be this regurgitant flow divided by the peak MR velocity, and regurgitant volume will be EROA into VTI. We should choose the velocity, aliasing velocity properly so that we get a proper hemispherical shape and not the oblong or a very flat shape. These are the advantages that few variables have to be seen. It is useful in stenotic and prosthetic valves and even in the regurgitant lesions. Disadvantage is that it is assumption that it is hemispherical, not useful in multiple non-hollow systolic and calcific valves, and PISA may eccentric jets are overestimated, and EROA in secondary is also overestimated. I have talked quite a lot just to give you an idea about the holosystolic and non-holosystolic, which is unique to MR and not to AR, that we should understand that even if the EROA is very large in non-holosystolic, it is there for only for a short period. So if we use the normal tracing, it will assume that it is throughout, and so we will overestimate the MR. So AROA will give us linear severity, while regurgitant volume will give us the actual volume overload. These are the 4, 5, 6 rules. We all know about the PISA, EROA, area, regurgitant fraction, regurgitant volume, and the width. And the 40-60 rule is the EF less than 60 and end systolic dimension more than 1. I will not go much in detail about the secondary MR, but it's usually due to 3 causes. All the 3 causes I have enumerated: the LA functional, ventricular functional, and ischemic remodeling. These parameters we have to keep in mind when we are dealing with ischemic mitral regurgitation. Previously, it was thought that 30 and 20 30 ml recurrent volume and ERO 20 should be considered in functional, but now this is not holding true. The values are same as that of the organic MR. Diastolic MR, which is seen with AV blocks and severe AR, should be kept in mind. 3D useful only during surgery for the NFAS view for the surgeons. When to use CMR? Mostly when there are multiple jets, eccentric jets, discrepancy between clinical findings, quantification, and multivalvular disease. So to conclude, we require high velocity, high quality echoes. It should be a compressive evaluation. Most methods are semi-quantitative, and the quantitative methods suffer limitations due to human, machine, and valvular geometry. Early referral to surgery is by quantification. Interpret in context of the patient, and a 3-dimensional wall requires 3-dimensional assessment. I will end by this quote given by Catherine Otto. Usually I can look at the color and tell if the mitral regurgitation is mild, and usually I can tell if it is severe. If it seems hard to tell, then it must be moderate. Thank you.
Thank you so much, Dr. Shah, for a very nice overview of echo in mitral regurgitation with excellent illustrations and the video examples. So we now move to the aortic valve, and I first request Dr. Harin Vyas to talk about aortic stenosis, the key issues as far as echo is concerned.
Sure, Dr. Bansal, thank you for giving the introduction. Is my screen visible?
Yes, sir. Please put in the full screen.
Yeah, I'm just doing that. So I'll be talking about the aortic stenosis assessment and what are the common pearls and pitfalls which we may come across. Most of the things have been talked about in mitral stenosis and mitral regurgitation, and the principle of any valve assessment remains pretty much same. So aortic valve is one of the two semilunar valves, this one present between the left ventricle and the aorta. It has usually three cusps, right, left, and the non-coronary cusp. When it is closed, it appears in Y-shaped. Let me just... So it appears a Y-shaped, and along with the valve, we also like to assess the aortic root with its three components, namely aortic annulus, sinus of Valsalva, sinotubular junction, and we also then assess the proximal ascending aorta, aortic arch. Remember, normal aortic valve area is around 3 to 4 centimeters square. Aortic valve is situated behind the pulmonary valve. So when we scan anteriorly from the chest, it is behind the pulmonary valve in front of the tricuspid valve when it is adjacent to the mitral valve. When the aorta is cut open, you can see the three cusps there. When there is coronaries involved, then this is either left or right, and you can see that the mitral valve is so close to the aortic valve. Now, the disease of the aortic valve is either degenerative, rheumatic, or it could be congenital. Degenerative, as we live longer, we see more and more of the degenerative aortic stenosis, but you can also see a rheumatic aortic stenosis, although it is more common for the mitral valve. Commonest congenital which we see in the adult group is the bicuspid aortic valve. And then you can also have a supra or subvalvular stenosis, which is either in the form of a discrete membranous stenosis in the alveoli area, or you could have a similar membrane in the supravalvular area, or you could have coarctation of aorta or other pathology. But we will stick to the aortic disease. Things you need to assess in any valve, but I'm talking about the aortic valve, is the structure. So whether it is appearing tricuspid, bicuspid, unicuspid, what is the thickness of the leaflet, how much is the calcification and where is the calcification, how mobile are the cusp, right? And is there restriction of one or more, are they prolapsing? What is the annulus size? How much is the calcium in this annulus? Because if there is a lot of calcification, then surgical option also sometimes becomes difficult. What is the aortic root? What is the annulus, aortic annulus, sinus of Valsalva, and STJ dimensions? What is the LV size, function? What is the aorta? So you always look at the structure below and above the valve. And of course, no study is complete without assessing other valves and other chambers. So how to assess? Of course, echocardiography is the key diagnostic investigation. It confirms the diagnosis of aortic stenosis and also tells you what is the cause for the aortic stenosis in most cases. There are other modalities which you can use to help the diagnosis of severe aortic stenosis by the dobutamine stress echo or a cardiac CT. What are the views which we need for aortic stenosis assessment? So we start with parasternal long axis view. That is important. Short axis view is very important. Apical 4 chamber with aortic valve open, we call it as 5 chamber. Apical 3 chamber, subcostal view, and a suprasternal view. And I will show you all these views in a minute. You need 2 dimension. So look at the leaflets, the mobility, calcification, and the aortic annulus. We use M mode, but it can sometimes cause confusion. And of course, color Doppler to look at the flow, acceleration across the valve, look at the regurgitation associated, and any other pathology if there is with it. And then we use the continuous and the pulse wave Doppler. So now this is how a normal aortic valve would look like. And you can see this is a Plaque's view with reduced depth, mitral valve, left ventricle, aortic valve, which is thin and mobile, and that is the aortic root and ascending aorta. When you put the color, you always follow a color image after you've taken a 2D image, and then you look for what is the flow acceleration across the valve and if there is any regurgitation. This is a cartoon here which demonstrates that when you are looking at the Plaque's view, what are the two cusps which you see, right? So this is a short axis. This is what the heart would look in a short axis. So you have a left atrium. So that's the left atrium. If you are cutting like this, so you can have a non-coronary cusp and a right coronary cusp. But if you cut slightly on this side, then you would have a left coronary cusp and the right. So you know for sure that on top, what you see here is the right coronary cusp. And the bottom is usually non, but it could also be a left coronary cusp. And that is the RVOT, which is the RVOT here. And that is when you put an M mode, you will see a nice big box where the aortic valve opens, because that's the QRS, it's in systole, the valve opens here. And then you have a closure line where the aortic valve closes, which is here in the diastole, and then the valve opens again here. So this is what you see in the M mode. We always measure the aortic root dimensions in a zoom view. So you always, in the same view now, we have zoomed into the aortic root and the LVOT area. And these are the measurements which we make. So we make the measurement of the aortic annulus, which is usually in the mid-systole when the valve is open. I have taken all these measurements here, but usually you would measure the SOV and STJ when the valve is closed. But it doesn't make a significant difference. But this is, I'm just trying to show you that you measure this how I measure in the 2D inner edge to inner edge. That is the STJ and a proximal ascending aorta. Here is the example of what an abnormal valve would look like. So the top one is a normal thin mobile valve. This one is a degenerative calcified valve with a restricted movement. Now M mode. So right, so we always look at the M mode and we say the box and the valve is opening fine. So now this image and this image, right, it is of the same patient where we have moved the probe one space above and one space below. So when I move a probe little one space above, I can see the valve is opening okay, whereas in this view I find the valve is severely restricted. So when I look at the short axis view, which is the extremely important view in the aortic stenosis, is you can see that the NCC is always identified by the interatrial septum. So if you see the interatrial septum, the adjacent leaflet, the cusp is non-coronary cusp. The one towards the RVOT is the right coronary cusp, and the other one is the left. So here what you see is the left one is calcified and static, whereas the non-coronary and right coronary cusp shows good mobility. So if I put a cursor across these two leaflet, then this is what would be seen. The valve is opening fine. And if I put a cursor across this, then I would see that the valve is stuck, and this gives me an impression that the valve is severely stenosed. So the short axis would clear the confusion in most cases. So M mode, yes, is helpful, but you need to be careful. Aortic valve in short axis view, as I have just demonstrated why it is important and why M mode can sometimes cause problem. If you have a 3D probe, you can always use an X-plane. So you look at the valve in two orthogonal planes, and you can then put the cursor at the tip of the leaflet, and then you can do a planimetry and get the aortic valve area. Now, short axis view, right? So this is how a short axis will tell you or help you in identifying different valves. So you see the first on the top here, this is a normal opening tricuspid thin and mobile valve, right? So you see a good opening here, and a valve is opening fine. This one is also a tricuspid valve, but left and the right coronary cusp are degenerative, fused, not moving, and a non-coronary cusp shows some movement. This one here at the bottom left is a bicuspid valve. Again, mild degenerative changes. You would see that the commissures are almost horizontal, 9 and 3 o'clock position. LCC, RCC appears fused. There is no raphe, but the valve opening is still fine. And this is another bicuspid valve, but there is a lot of commissural calcification, and the cusp separation is reduced. Right? So short axis would help you in identifying all these different morphology of the valve. Classification of the bicuspid aortic valve is simple. If you have no raphe, it is right in the center, 9, 3, 12 and 6, then it is true bicuspid aortic valve. You could have a commissures, vertical or horizontal. Depending upon which two cusps are fused, you could have a bicuspid valve type 1A, B, C, and you could have a unicuspid valve if both the commissures are fused. Now, to assess the aortic valve gradient, which we need for most valves, you do need a CW and PW to get the gradients across the valve. You use apical 4-chamber with aortic valve open, or you call it as 5-chamber, and you use the apical 3-chamber, right? Now you first put the color flow, and you always do CW along with the flow of the colors. You want to ensure that you align as much as possible with the color flow, right? Because the more the angle, lesser is the gradient, and you may have underestimation of the stenosis. So put color flow, look at the flow acceleration, turbulence across the valve, align your CW, Doppler, and then get the gradients across the valve. Ensure that you have taken multiple gradients with multiple alignments to ensure that you have not missed the highest gradient. Then do a pulse wave Doppler in the LVOT area so that you can use the continuity equation and you can get the stroke volume by using the LVOT diameter and LVOT VTI. So when we look at the apical 5-chamber or 4-chamber with the aortic valve open, this is how you will see, and you can put a color Doppler. You see a nice laminar flow. There isn't much of a turbulence. There is a little bit of aortic regurgitation there. And then what you do is you put the color, the CW, and you ensure that you've aligned with the color, and then you get the gradient. So in a normal aortic valve, when the cusp separation is opening well, you won't get a high gradients. The velocity is around 1 meters per second. This is where you see from the scale, which is on the right side. And in apical 3 chambers, sometimes you get a better alignment here. So you look at the apical 3 chamber, again put the color, and then you can do the CW, right? PW is that the cursor is right in the LVOT area, just below the aortic valve. And what you will get is this kind of a waveform. So if in a normal opening valve, the CW and the PW gradients are going to be pretty much same. But in a stenosed valve, the CW is going to be higher because it's going to give you gradients across the aortic valve, whereas the LVOT is going to give you the gradients right in the LVOT, so that you can use continuity equation. Now, in severe AS, when you get the CW, this is how a high gradient. So you see the previous one, it was 1 meter per second, and here you would see it's about 4.5 meters per second, which is mentioned here, and you get a gradient of 84/50 as the highest gradient here, right? If you don't get a good alignment, you can also use a non-imaging probe, which is shown here, and you will see that you can still get a gradient, but you don't have the image on top. So you don't have this image, which you normally get with the CW. In a non-imaging probe, you will not have that image, but sometimes you can get a higher gradients with a non-imaging probe. So keep that in mind. If you have an associated other valvular pathology, or you have an associated AR and MS, then 3-chamber will help you in differentiating both these conditions easily. So keep that in mind. Aortic arch is part of the echocardiography and must be done. You will find significant findings in some of the patients, which would really change the course in the treatment. So what you usually see in the aortic arch is the right. So you see the 3 branches of the aortic arch. So you see the left subclavian and the left common carotid and a brachiocephalic. So you see the brachiocephalic there, and then the 2 branches here. Okay, and this is the aortic arch, and then the descending aorta starts here. So when you do this on a routine basis, nowadays a lot of people want to do TAVI. So if you pick up these important findings, then they can be either not do a TAVI or be careful. So you see here we found an aneurysm of the common carotid artery, whereas we found a PDA, associated PDA. So along with the aortic valve, you would also need to fix this. We found a thrombus hanging right at the ostium of the left common carotid artery. So, this could dislodge and give a stroke. And there was an atheromatous plaque opposite the common carotid artery. So, suprasternal view is extremely important and should be done in all patients. Subcostal view could be the only view in COPD patients. So again, do not end your study saying there are no views. Look at the subcostal view. You will be able to see the aortic valve in most patients. And you can sometimes get a better view of the aortic valve to differentiate between bicuspid and tricuspid from a subcostal view. So these are the common views which you would want to take in all the patients where you are assessing aortic stenosis. So complete and comprehensive study, ensure you looked at the LV size and its function along with, so if you have a severe aortic stenosis, you are likely to have some left ventricular hypertrophy. Look at the other valves and see what is the impact of long-standing aortic stenosis on the right side of the heart and if they have developed any pulmonary hypertension. So for severe aortic stenosis, the aortic valve area should be less than 1 centimeter square. The mean gradient has to be more than 40 and the max gradient has to be more than 60. So let me show you very quickly 5 scenarios which you may come across, right? So we've obviously now looked at the normal values, abnormal values, what the views are needed. So now this is case 1, right? Patient has left ventricular hypertrophy, which you can see from here. The IVS and the posterior wall appears thickened. Mitral valve seems okay. Left atrium is a little dilated. Your aortic valve appears thickened. Like we saw the previous normal aortic valve. As compared to that, this valve is thickened. The movement, so then I put a zoom just to show you, and the valve appears again thickened, not opening very well. Again, this is another angle here. The valve is thickened, not opening very well, right? Now, say if this patient comes with a fever, then I'm going to think this is a vegetation. Okay, but here I'm just, now we are sticking to the aortic stenosis. So the valve shows degenerative changes, thickened and not opening well. Zoom view, we measured the SOV, STJ and the proximal ascending aorta. We put the color. We see there is some MR, there is also mild to moderate aortic regurgitation, and there is a flow acceleration across the aortic valve. In the short axis view, you can see the aortic regurgitation on the top here, right? So this one is the aortic regurgitation. This is the mitral valve opening, and there is some mitral regurgitation as well. When you look at the aortic valve in the short axis V, in a zoom view, you see the aortic valve is so thickened and the opening is right in the center and it's very tiny. Okay, you can also use the M mode to look at the aortic regurgitation, which is seen here, right? So this is the flow acceleration across the valve, and then in the diastole, when the valve is closed, you shouldn't be seeing any flow, but here we see the flow, so that again says that there is a regurgitation through the aortic valve. Then, as I said earlier, we will then use the apical 4-chamber. We keep the aortic valve open, put the color, and then use the CW aligned with the flow and get the gradient. So what we get is 147 as the max and a mean of 103. So severe aortic stenosis with preserved LV systolic function, and there is LVH. So that is what we reported. So LV was dilated. As per the volume, there is LVH. Severe aortic stenosis, it is tricuspid valve, and the gradient is 147, 103. Associated MR, mild to moderate pulmonary hypertension, and we saw there was a mild circumferential pericardial effusion. Scenario 2. Again, so plaques view, aortic valve degenerative, not opening well, but not as thickened as the previous, but the restriction of the movement is significant. Short axis, again, not a great view, but the tips retain some mobility. Otherwise, the valve appears static. When I put a color, there is flow acceleration. Unlike, it's not like the first scenario, but there is some flow acceleration through the valve. When we get the gradient, what do we see? We see different gradients there, right? Because if you have noticed, then the patient is in atrial fibrillation. So the ECG tracing shows that the patient is in atrial fibrillation. So we have then traced more than one, and what we are getting is not a very high gradient, right? So if you were to go by gradient, then we will say this is not a significant aortic stenosis. but LV function appears okay. So you see the systolic contraction in 3 chamber, 2 chamber, and 4 chamber is okay. So we said that this patient has atrial fibrillation. LV size, the patient has mild to moderate concentric LVH. Function is preserved, and we feel that the aortic stenosis is significant. However, gradients are low, and this could be because of paradoxical low flow. And we said transesophageal echo would help. So always, if you have a doubt, then ask for another test, and transesophageal echo would be your next test to get a better view. So same patient now, we've done a transesophageal echo at about 120 degrees, which is a 3-chamber equivalent in the transesophageal echo. Short axis view, you can see the aortic valve has significant commissural calcification. There is only movement some at the tip. And so the planimetry here, which we did on transesophageal echo, shows the valve area of about 1.07. So again, falling into the severe category.
Dr. Aryan, we'll have to end in 2 minutes maximum.
Yeah, sure. So that is what we reported here. And you can always do a dobutamine stress echo to try and see if there is a low flow, low gradient. Scenario 3, degenerative valve, flow acceleration, LV function is down, valve is severely stenosed, and we are getting significantly high gradient. So LV function is poor, high gradient, severe AS, severe LV dysfunction, and GLS is very low. Another scenario, so now again heavily calcified degenerative valve, you can see it on the short axis view. LV is severely down, appears dilated, but gradients are not high. So previous scenario, severe LV dysfunction, severe AS, but high gradients. Here severe AS, severe LV dysfunction, but gradients are low. So this is a low flow, low gradient aortic stenosis. That is what we reported. And this one is a scenario 5 where patient has good LV function. The valve appears little different. It is bicuspid valve. You can see it in the short axis view. It is opening well. However, the gradients are high, 54-26. So falling into the moderate category, mild to moderate. But we can see from the opening that it is not a narrow opening well, about 3 centimeters per square is the opening. So normal opening bicuspid valve with high gradient. So basically, what we have seen here, I'm just going to forward this because so there are 5 scenarios. What you saw was severe aortic stenosis, normal ejection fraction, high gradient, no confusion, right? We know this is severe AS. Another case, severe aortic stenosis, ejection fraction was normal, but there were low gradients and valve area was less than 1. So this was paradoxical low flow. Third scenario we saw was a severe aortic stenosis, but ejection fraction was reduced. Gradients were very high, valve area was less than 1. Again, this is severe aortic stenosis, but low EF. Fourth scenario, severe aortic stenosis, reduced ejection fraction, gradients also low, and this is a low flow, low gradient aortic stenosis where you can also use the dobutamine stress echo. And the last one we saw that the aortic valve was bicuspid, but opening well, ejection fraction was normal, but gradients were high and the valve area was more than 1. So remember, there are other few things which you can use to assess the aortic stenosis. See what is the exercise capacity of the patient. Look at the stroke volume. Look at the Doppler velocity index. Obviously, I don't have time to discuss all this thing. Use calcium score of the valve if required. Cardiac MRI can be helpful in some cases. And obviously, look up for associated coronary artery disease. So true aortic stenosis, high gradients and normal LVEF is fine. If you have reduced LVEF but you have high gradient, this is still true aortic stenosis. If you have lower gradients, normal LVEF, think about the paradoxical low flow, low gradient aortic stenosis. And if you have low EF, low gradients, but if you still feel clinically is aortic stenosis, then think of the low flow, low gradient aortic stenosis, right? Paradoxical low flow, when the gradients are below 40, valve area is less than 1, ejection fraction is more than 50, and a stroke volume is less than 35 ml per meter square. This is usually patients with hypertrophy, elderly. So HOCM, HCM patients could have paradoxical low flow, low gradient. Low flow, low gradient is where the gradients are low, stroke volume is low, ejection fraction is also low. High gradient but normal valve area. So be careful in bicuspid aortic valves. You could have a normal opening valve, but the gradients can be high. So remember this thing. This is explained by either an eccentric jet, which gives high gradient, or you could have a localized obstructions, a calcium or something, which can also cause high gradients across the aortic valve.
I think, Doctor, yeah.
I'm done. This is the last. So remember, aortic stenosis is mainly diagnosed on echocardiography. Complete comprehensive echo is must. Be careful if the gradients are not high enough, because you could be dealing with low flow or paradoxical low flow, low gradient. If the gradients are high but the aortic valve is opening, you could be dealing with the pressure recovery phenomenon. Ensure appropriate patient selection for intervention and non-intervention. Guidelines are there to guide you, but not a rule book. Thank you.
Yeah. So thank you so much for an extensive coverage of echo in AS. Now we will move on to the next presentation, and for this I request our senior most faculty member here, Dr. J.C. Mohan, who doesn't need any introduction, is I should say the most respected and regarded name in the field of echocardiography, has been teacher to all of us. So over to you, sir.
Dr. Mohan sir, we can hear you.
Thank you, Dr. Bansal. We would be talking about echocardiography evaluation of aortic regurgitation. Am I audible?
Yes, sir. Now you are audible.
So, non-rheumatic valvular heart disease is the epidemic of this century, and it's estimated that people who are above the age of 65 years, at least 6% have moderate or severe valvular heart disease. The ACCHA class, the staged valvular heart disease from at risk to severe symptomatic valvular heart disease, ABCD, and also actually gave stage 1, 2, 3, 4 of, depending upon whether only left ventricle is involved or left atrium gets involved, pulmonary circulation, and the right ventricle gets involved. As far as aortic regurgitation is concerned, passes through a compensated stage, transitional stage, and decompensated stage. And our job is to pick up these people in transitional stage so that, especially if severe, so that early intervention can be done. Aortic valve, or also known as left side semilunar valve, actually guards the left ventricle outflow tract and directs blood flow to aorta during systole. But it is a simplistic view, as we said. The aortic valve actually has a complex involving leaflets, annulus, root, descending aorta, alveoli, aortomitral curtain, and of course the commissures. Normally there is no backflow. That means there is no aortic regurgitation in the valve. And we also have to understand this thing that, as I already said, the anatomy of the aortic valve complex should be well known. We should know what is sinotubular junction, what are sinuses, how much is the height and width, and which is the true anatomical aortoventricle junction, and what is the virtual aortic annulus. I wouldn't go in those details. Part of that has already been taken care of by Dr. Vyas. However, when the blood actually during diastole regurgitates from aorta into the left ventricle, we call that as aortic regurgitation, and the reason is shown here on the right side of the picture, and that is because you see an orifice which is left during diastole, and this is the regurgitant orifice area. This is anatomical regurgitant of orifice area, and more is the regurgitation through this orifice. Higher is the left ventricle preload, and higher is the left ventricular afterload. Half of the pure severe aortic regurgitation valvular in origin, and another half actually is aortic in origin. Here are the multiple causes, valvular and aortic causes. We would not go in those details, but it's necessary to know these causes. And we also have to remember that nearly 1/3 of all bicuspid aortic valve end up having significant aortic regurgitation, often accompanied by aortic root dilatation. And the recent classification of the bicuspid valve calls them trisinus bicuspid valve or bisinus bicuspid aortic valve, the upper being tricuspid with a raphe and lower being a bisinus bicuspid aortic valve. Like the Carpenter's classification of MR, there is this classification of aortic regurgitation also, type 1, type 2, and type 3. We are going to rely upon the most recent guidelines of the British Society of Echocardiography, given few months back about assessment of aortic regurgitation. And the guidelines start with saying that assess the valve and its complex, assess extravalvular damage, assess the regurgitation severity. Now, the regurgitation severity has to be quantitative, and unfortunately, most people don't do a quantitative analysis of aortic regurgitation. We need to understand the concept of the total stroke volume, which goes across the aortic valve, the forward stroke volume, which is actually the stroke volume which is present at the mitral valve or pulmonary valve, and of course the regurgitation volume, which is the difference of the two, and of course the regurgitation fraction, which is the regurgitation volume divided by the total stroke volume. The British Society of Echocardiography says if the regurgitation volume is less than 30 ml in adults, it is mild aortic regurgitation. More than 60 ml is severe. It doesn't talk in between whether you should be calling, which level you should be calling moderate aortic regurgitation and which level you should be calling moderately severe aortic regurgitation. So from a clinical viewpoint, these things are important. Either you have mild aortic regurgitation or severe aortic regurgitation. Similarly, the British Society Echo talks about the regurgitation orifice area by PISA method. Severe if the valve area is more than 0.3 centimeter square and mild if it is less than 0.1 centimeter square. In between, well, you could call it moderate or moderate severe. However, we need to keep in mind that regurgitation orifice area is a big issue because you assume circular in most of these situations. It can be oval, it can be semilunar, and it can be very, very irregular. And that would create a lot of difficulty in assumptions. So we, as has been pointed out, Dr. Haran Vyas and others, that there should be a multi-parametric approach, quantitate and look for specific signs. No single magic number is enough to quantitate aortic regurgitation. Each method has intrinsic error, and valve and aorta morphology both are important. The British Society Echo 2025 guidelines talk about qualitative parameters, which are, of course, valve morphology, coaptation, LV size, CW, Doppler density, and flow reversal descending thoracic aorta. The semi-quantitative vena contracta, pressure half time, velocity flow, size of the color flow jet, and the quantitative parameters remain constant: regurgitation volume, regurgitation fraction, regurgitation orifice area. The ACCH actually gives a different kind of way of assessing aortic. It talks about quantitative data, which is similar, specific signs, and of course, supportive signs. There's a mix-up of specific and supportive sign with regard to the ACCH evaluation vis-a-vis British Society of Echo. We will discuss these quickly, actually. A typical rheumatic aortic regurgitation, and how do we know? You just look at the mitral valve and know the patient has mitral stenosis, and of course there is this turbulent flow leaking from the aortic valve in the left ventricle, and of course this is aortic regurgitation rheumatic. Infective endocarditis, the vegetations on the aortic valve, and of course the severe leakage you can see in this particular individual. These are both patients are acute or subacute aortic regurgitation. But we wouldn't try to differentiate acute and subacute in this presentation. But you, of course, have to look at a lot of things actually to arrive at a diagnosis whether it is severe aortic regurgitation or not. One of the things which we have to understand is that the color flow mapping plays a big role, and you should be able to identify all the three zones: proximal flow convergence, vena contracta, and divergence zone, the 1, 2, 3 zones, in case you want to make any sense out of quantitation of the aortic regurgitation. But morphology is important and 3D is important. Suffice to say, 3D might show you something which you don't see in 2D. Here is an example of a perforated right coronary leaflet, which causing severe aortic regurgitation, you are able to pick up clearly here. This is the orifice actually. This is the orifice which you are seeing. The anatomical regurgitation orifice area, rarely you are lucky to be able to estimate the planimeter it. These are usually about 15 to 20% bigger than effective regurgitation orifice area measured by PISA method. But whenever available, you should measure it and take 0.4 centimeters square as the severe aortic regurgitation and less than 0.2 centimeters square as mild aortic regurgitation. But you might use a 3D, you might use 2D, but keep in mind that you may not always be able to get so nice pictures as shown here. We also have to understand that type 1, 2, 3 has to be talked about, and the reason why you have to talk about is that when the aorta dilates, not only it becomes type 1 initially, it also can become type 3 with tethering of the leaflets as shown in the picture on the right side. Sometimes, of course, the aortic regurgitation can be because of funny reasons. Here is a cord-like structure attached actually to the non-coronary cusp, and this has been described. We have discussed these things. Actually, Dr. U.P. Singh keeps showing these cases in small children. This is an adult, 27 years old. So the British Society of Echo talks about jet flow width to LVOT diameter as one of the important parameters of semi-quantitation of aortic regurgitation. Measure in mid-diastole, the jet flow width to LVOT width if less than 25% indicates mild AR, more than 65% indicates severe AR. And of course, the guidelines don't talk about in between. What should you label it? Obviously, in between will be moderate or moderate to severe. Take your pick, divide them in two or divide in one. It is your choice. The BSc gives it to you as a matter of fact. Here is an example of a color flow, which is filling the entire left ventricular outflow tract. Obviously, it is severe aortic regurgitation. Here are the examples of mild on your left side, and of course on your middle and the right of, for example, severe, where the jet width divided by LVOT width is more than 65%. Or the vena contracta is the second important thing. A lot has been talked about vena contracta by Dr. Shah. And of course, before you measure vena contracta width in parasternal long axis view, which is perpendicular view, you should be able to show the proximal flow convergence, narrowest portion just as the jet exits the valve orifice, and of course the jet expansion or the divergence. Those are important issues. Vena contracta, the British Society Echo says, now the British Society Echo says that severe if it is 6 millimeter or more and mild less than 3 millimeter, moderate 3 to 5.9 millimeter I have written because the British Society Echo says this is, you can divide into moderate and moderate severe depending on which way you want to go about. The vena contracta is surrogate for effective orifice area. Monoplane is as good as biplane. Parasternal long axis view is the best view to measure the vena contracta. Of course, many people have suggested biplane view, like Maurice Serrano from Mayo Clinic. It has no geometric assumptions as in PISA and not affected by instrument setting, gain, Nyquist limit, hemodynamics, blood pressure, etc. And is equally valid for central and eccentric jets with a sensitivity of 95%, specificity of 90%. The British Society Echo 24 says that the non-circular orifices you will misjudge vena contracta, and 3D is better for vena contracta area rather than measuring vena contracta diameter. Here is the 3D. You can actually go down and 3D on the left side, 2D on the right side. Even 2D vena contracta area can be measured, although there is entrainment phenomena, and it is slightly bigger than the effective orifice area measured by vena contracta. But a recent study has shown that 0.34 centimeter square measured by the color flow vena contracta area, 2D area, is a pretty good estimate of a true effective regurgitant orifice area. For 3D, of course, bigger figures have been quoted. We wouldn't talk about that. Basis of vena contracta, we have already discussed, and I wouldn't talk about that. But keep in mind that the eccentric aortic regurgitation creates difficulty in measuring vena contracta or jet width to LVOT height. The important thing I said is you have to show all the three components, regurgitant flow while measuring vena contracta. And the ultrasound beam should be as perpendicular to flow as possible. Always use zoom mode. Automation is better, and automatic vena contracta being measured more and more by the newer machines. And here is an example where you can see all the three views actually: PFC, vena contracta, and of course zone of divergence. Pressure half time, the next thing, it is a supporting sign according to the ACCHA, but it is a semi-quantitative method according to the British Society. Echo pressure half time of the continuous wave spectrum of aortic regurgitation less than 200 milliseconds is severe, more than 500 milliseconds is mild. And as I said, British Society of Echo leaves up to you between 200 to 500. How would you like to label it, moderate or moderate severe? We know that this pressure half time is affected by LV compliant dysfunction and hypertension grade. Example of a mild aortic regurgitation where the pressure half time is 690 millisecond. Example of severe where the pressure half time is less than 200 millisecond. Measured in 3 consecutive beats, it comes to less than 200 millisecond, indicating severe aortic regurgitation. The previous studies have shown the lower sensitivity of pressure half time, but specificity is high. I will show you some recent studies as well. But sometimes, of course, there is confusion. If you look at this 42 years male with Marfan syndrome, by pressure half time of 357 milliseconds would tell you that it is neither severe nor mild, is in between. But when you look at the vena contracta, 10 millimeter tells you it is severe aortic regurgitation. So even you may have actually, you may have poor sensitivity of pressure half time as shown in this particular case. Flow reversal, descending thoracic aorta and abdominal aorta, all the other supportive signs are also called as semi-quantitative sign, depending on which method or which guideline you are following. Flow reversal, descending thoracic aorta with end diastolic volume more than 18 centimeter per second indicates severe AR according to British Society of Echo with a sensitivity of 45%, specificity of 87%. Hollow diastolic flow reversal actually has a sensitivity to 63%, specificity 77%, according to another study. And a flow reversal abdominal aorta indicates severe AR according to the British Society Echo guidelines. You can measure the velocity time integral of the reverse flow velocity time integral more than 13 centimeter present in moderate to severe aortic regurgitation. It is not mentioned in British Society Echo 2025 guidelines whether BTI has any significance or not, but studies have shown that more than 13 centimeter is present in 91% of severe aortic regurgitation. Just keep that thing in mind. Of course, if you don't see proximal flow convergence, the aortic regurgitations are usually non-severe. That is all we can say about that. 3D echo on AR gives you direct area of vena contracta and also regurgitant volume. You can get LV stroke volume minus the RV stroke volume, and you would get the regurgitant volume. We have talked a lot about the proximal flow convergence, especially Dr. Rajesh talked about it, and of course he showed you nice pictures how to measure actually regurgitant volume and the regurgitant orifice area. This is one example, but in eccentric area, eccentric aortic regurgitation, you can't rely on PISA. PISA has a lot of assumptions, like it is always hemispheric, that the orifice is circular. Things are not that easy actually. But if you see if you see actually the radius of the hemisphere is more than 7-8 millimeter, usually it is significant aortic regurgitation. But this method actually has to be used in more often in 5-chamber or 3-chamber views. And mid-systole is the one when we should measure the continuous wave Doppler spectrum with regard to the VTI and with regard to the peak velocity. These were the previous grading systems actually given by the Mayo people, but currently, as I told you, British Society Echo says less than 0.1 centimeter mild, more than 0.3 centimeter regurgitant orifice area is severe, in between your guess. You can also use actually the stroke volume of the mitral and aortic actually to get the regurgitant volume, as I already talked to you. You can also get regurgitant volume by 2D method and Doppler method, or combined 2D and Doppler method. which of course will be a lot of assumptions and a lot of errors are possible. This is how the ERO is measured. I think Dr. Rajesh had took you through. I wouldn't take you through, but direct measurement of PISA with real-time 3D echo is feasible for AR without relying on hemisphere assumptions, and this method provides more accurate estimates of aortic regurgitant volumes. Extra valvular damage in AR should be seen by LV size, volume, ejection fraction, global launcher strain, LAVI, left-gated reservoir strain, PA pressure assessment, LV mass, like for any other valvular heart disease. Quickly, we know that patients of the aortic valve replacement is needed for symptomatic severe aortic regurgitation and those who have ejection fraction less than 55%. And of course, there's a class 2 A indication for based on size, left ventricular systolic diameter more than 50 or more than 25 millimeter per meter square. In asymptomatic but severe AR, you also actually have other criteria, but the ejection fraction has been dropped from 50, has been upped from 50 to 55. That has to be remembered. There is also 2B indication for left ventricular end diastolic dimension more than 65 and progressive fall in ejection fraction. A word about the global longitudinal strain. It is a 2B indication. It has been suggested that less than 18% global longitudinal strain in severe AR might constitute an indication with class 2B recommendation according to ACC/AHA guidelines on valvular heart disease 2021. Let me just show you the sensitivity and specificity of the various parameters in a quick manner. Cardiac output more than 10 liters, sensitivity 53%, specificity 89%. What is the best specificity? The PHT, unfortunately, has a very low sensitivity of 12% and specificity 100%. That is true. Diastolic flow reversal also sensitivity is low, 45%, specificity 80. Something which comes closer to actually single parameters, vena contracta, with a sensitivity 81%, specificity 83%. So if you have to use a single parameter, a parasternal long axis view, zoomed up view, and proper measurement of vena contracta width, probably will give you a pretty good idea about severity of aortic. You can also use the rule of 50 for intervention, ejection fraction less than 50%, and systolic diameter more than 50 millimeter, regurgitation fraction more than 50%. Those are some of the people try to make the things easier. So ladies and gentlemen, to summarize, for assessment of aortic regurgitation, use a multi-parametric and multimodal approach. We have not talked about multimodal approach. We did not have time, but that is very essential. Quantitate and look for specific finds. As I said, no single magic number. And of course, keep in mind that you have to measure the LV and aorta morphology. Both are important. Thank you very much.
Thank you very much, sir, for very nicely covering all the most relevant aspects about echocardiographic assessment of AR. And now that we have covered all the 4 topics, we can take a few questions. Before that, I thank all the speakers from my side for very nicely reviewing echocardiographic assessment of all the 4 major valve lesions. These are very vast topics. Time was short, but still all the relevant topics were very nicely covered. So personal gratitude from my side. Now we can look at the questions. So first is for, I think sir can answer. So patient has bicuspid aortic valve and moderate AR. Transthoracic echo shows progressive aortic root dilatation. Which parameter would suggest earlier surgical consideration?
So in presence of bicuspid aortic valve, current recommendations are 50 millimeter of aortic root or ascending aorta dilatation of width is a class 1 indication. In case there is associated aortic regurgitation, this changes to 55 in case there is no AS or AR. In presence of AR and bicuspid valve, 50 millimeter is a class 1A class 1B indication for aortic valve replacement along with the replacement of the root. That means Bentals or David procedure, depending upon what you are looking at.
Yes, sir. So a question for Dr. Harin Vyas. A patient with severe AS and no symptoms, but shows progressive LV hypertrophy and elevated natriuretic peptides, what would you recommend? How would you approach this scenario?
So for the asymptomatic severe AS, as I said in my, some of the last slides, is that you must assess the patient's functional capacity also. So you can always put them on the treadmill and you can do a sequential treadmill, see what the exercise capacity is, what is the inotropic and chronotropic response, if they have a blunted response or there is a drop in blood pressure, that would become an indication. Along with the asymptomatic patient, you look at the LV size also. If LV is dilated, then also there is an indication to go in early and replace the valve, and also if there is a development of the pulmonary hypertension. So if this patient has elevated BNP, you would want to assess the echocardiographic pulmonary hypertension, and if it is showing elevation as compared to previous study, that could also be an indication to go for the AVR.
I just wanted to point out that there are
Yeah.
3 randomized studies which have shown that severe asymptomatic AS per se is an indication for intervention. These studies are AVATAR, Recovery, and TAVR Unload.
So I think that with time we will be moving towards in this direction only. Severe AS, once we document it, becomes an indication for intervention, especially in the era of TAVR, where the surgical risk has gone down. And even we have data for moderate AS also in patients who got used transvalvular flow, they may have a better outcome with intervention. Now, there's a question for Dr. Shah. In patients with ischemic cardiomyopathy and functional MR, what echo parameter is most predictive of poor surgical repair outcome?
I had shown that slide, but I had to rush through it. The cooptation distance and cooptation depth, if it is more than 1 centimeter, then tenting area, if it is more than 2.5 centimeters, and the posterior leaflet angle, if it is more than 45 degrees. These all indicate that the prognosis is good. It's a severe MR. Also, the significant remodeling indicated by end diastolic dimension more than 65 and end systolic dimension more than 51 centimeters. Then the systolic sphericity index more than 0.7, systolic interpapillary muscle distance of more than 20, and end systolic volume more than 145 ml. All these constitute parameters which indicate poor outcome.
Yeah, basically, more is LV remodeled and less is LV systolic function. Worse will be the outcome of valve repair, and overall outcome, clinical outcome is also going to be worse. I think these were the only questions that we had. So before we can have comments from our speakers, I would just like to re-emphasize one point which came out very nicely from all the 4 presentations, is that in any valve disease, it's extremely important to look at the valve morphology in 2D, in grayscale, because that will not only give us information about the etiology and mechanism of the lesion, but will also give us a lot of information about the severity of the lesion. Those who are doing echo, they tend to commit this mistake that they jump onto Doppler parameters, whether color or spectral, believing that those are the parameters that will tell us about the severity of the valve lesion. But it is not true. 2D plays a very, very important role. Just grayscale examination of the valve, whether it is MS, MR, AS, AR, will tell us a lot about the severity of the valve lesion. So, sir, any comments from your side? Any other speaker?
I just want to make 2 benign comments. Dr. Vyas said that he likes to measure the aorta inner edge to inner edge. Of course, we know that the ASC suggests leading edge to leading edge, and we need to keep in mind. Number
Sir,
2, of
ASC
course, pardon?
So British Society
ASC
Echocardiography suggests the inner edge to inner edge, and I follow
yeah, but
BSc.
the inner to inner edge actually suggests when you are comparing against the CT, because you are seeing lumen to lumen. But since all the interventions have been based upon that parameter, the ASC suggested. But anyhow, that is one point. The second point, of course, benign comment is to Dr. Grewal. The aortic stenosis, aortic valve area and aortic gradients are flow dependent. And mitral gradients are heart rate dependent, largely. We need to understand the difference between the two. From a heart rate from falling from 80 to 76 can bring down the gradients to half of what they were. That wouldn't happen in aortic stenosis where flow makes it different. So I always want to, that comment should always be told to everybody that mitral valve gradients are heart rate dependent and aortic gradients are flow dependent. Those are the only two comments I wanted to make.
So we can say that gradients are flow rate dependent. Then that will be applicable to both valve regions.
Absolutely. Yeah, that is true. But you know, we don't calculate. To calculate flow rate, you need a lot of parameters.
Yes, sir. Any other comment? Any last comment from Dr. Vyas, Dr. Grewal, Dr. Shah?
I think just a comprehensive echo study, all images, no shortcuts will answer most of your questions, to be honest.
Yes, that's true.
But Dr. Vyas, having seen that, I regularly see reports of MR and AR. Nobody puts any quantitative data. There are semi-quantitative data, but nobody is putting quantitative data with regard to regurgitant volume, regurgitant fraction. And that is the major difficulty of reporting in India. We keep presenting, and I have to accept that even we are guilty of that. I'm not saying about others. Even I am guilty. Even if I do quantitation, I probably might mention regurgitant volume. I would not mention the other two. I think we need to be a little more methodical and more comprehensive.
Yes, sir.
I mean, I accept that we all are doing the same mistake, and much more is being done at other levels.
So, Dr. Navya.
Yes, so as we are moving to the end of the discussion, so now I would like to thank heartfelt gratitude towards our course director, Dr. Manish sir, for excellently moderating the session by putting forward your thought-provoking viewpoints as well as sharing the questions of the audience. And also I thank the faculty members, especially Dr. J.C. Mohan sir, Harin Vyas sir, Dr. Rajesh sir, and Dr. Hardeep ma'am. It was an excellent and a phenomenal talk and a very extensive talk, and we got to know about the understanding about the echo in mitral stenosis, regurgitation, as well as aortic stenosis and regurgitation. So hope we keep up the learning ahead. And I also thank the audience. So there was 800 plus audience who has participated today's session, and I hope the audience will be really benefited out of today's excellent discussion. And also they have also answered the audience poll questions, and thank you for the same. And I also thank all my Glenmark team, commercial as well as the IT team, and all the support which has been provided. And we'll be looking forward for the next webinar series, which is upcoming in the next month, 13th September. So where we will be talking about the part 2 of valvular heart disease. And I hope to see all the audience in that webinar also. So thank you so much for having in this happy Raksha Bandhan day to put forward your clinical pearls and insights to today's discussion. So thank you so much. Have a sweet night ahead.
Thank you.
Thank you. Same to you. Thank you.
Good night, everyone.
Good night.